Hi class, in this lecture I'll talk about antifungal agents. The objectives are listed on the slide. They're also listed in your Blackboard module. Please review relevant vocabulary and be familiar with the definitions. Alright, so antifungal agents that we'll talk about will fall into two major groups: the drugs that we use for systemic fungal infections or the drugs that are used for superficial fungal infections. Even though superficial is listed first on this slide, really this lecture is going to focus on the treatment of systemic fungal infections. These are more serious, they're more difficult to treat, and the drugs that we use in the hospital setting particularly are the drugs that we're going to talk about. I will touch briefly on superficial infections at the very end of the lecture. So let's just talk about the systemic infections for a moment. Those can be broken up into two categories, either opportunistic or non-opportunistic. The opportunistic infections, fungal infections, these are usually seen in immunocompromised patients, and these can be very serious, very deadly. Some of them you may have heard of: candidiasis, aspergillosis, cryptococcus, mucormycosis. These are just some of the infections that likely you guys will see in clinical practice. Some of the non-opportunistic infections, blastomycosis, histoplasmosis, these are just some examples. All in all, especially for the systemic infections, treatment is difficult. These infections often resist treatment. They may require prolonged therapy, and the drugs themselves tend to be more toxic than what we see with antibiotics or even antiviral agents. And this is because the fungus cell is somewhat similar to a human cell. And so because of that, there's overlapping toxicity. So let's get into the pharmacology. There are 4 drug classes that we're going to talk about.
So the 4 drug classes are the polyene antifungals, the azole antifungals, the echinocandins, and the pyrimidine analogs. By far, you will see the first 2 much more commonly in practice than the last 2, but all 4 of these are included in your NCLEX preparation materials, so we are going to talk about all 4.
All right, so let's talk about polyene antifungals. Our prototype is amphotericin B. In parentheses, it says conventional, and that is because there are 2 forms of amphotericin B. There is the conventional form, and there is the liposomal form. They are different. They have similar actions and similar uses. However, the dose for those drugs is different, and that's why you see the dose bolded on this slide. So these drugs work by binding to ergosterol, which is specific to fungus, and it forms pores in the cell membrane, which leads to cell death. Therapeutic use: this drug is broad spectrum. It's used for a variety of fungal infections, and in fact, it is the drug of choice for most systemic fungal infections. It also has activity against protozoa. As I mentioned, the dose is bolded on the slide. That means you need to know it. You need to be familiar with the dose of conventional amphotericin B. It is 0.5 to 1.5 milligrams per kilo per day. The dose that is used for conventional amphotericin B is lower than the dose that is used for liposomal. And the reason I point this out, it is unusual for me to ask you to remember doses, but the reason I point it out is because so many cases that I investigated of overdose of amphotericin B or potential overdose, the medic was prescribed incorrectly, was dispensed incorrectly by pharmacy, and in a lot of the cases that I saw, the error was detected by the nurse. So prior to administration, the nurse realized that this was incorrect. So I want you guys to be familiar with this dosing so that when you're at the bedside, you can detect this error, because it will inevitably happen. The duration, this drug is given 6 to 8 weeks, or it could be up to 4 months. Adverse effects. The one that I have bolded on the slide that's very important for you all to know is infusion reactions. These are related to pro-inflammatory cytokines that are released when this drug is given. It can cause fever, chills, rigors, nausea, headache. Usually starts within the first couple hours after the infusion. So that is definitely an important one to be familiar with. The drug can cause phlebitis, so the IV site needs to be monitored. This drug can cause nephrotoxicity. In fact, this is one of the most important adverse effects associated with this drug. The good thing is that once the drug is discontinued, the kidney function will return to baseline usually. But when this drug is administered, kidney function, serum creatinine have to be monitored. The drug can cause hypokalemia, can also cause hematologic effects.
So the drug interactions we worry about with amphotericin B are drugs that can also cause nephrotoxicity. When those drugs are used together with amphotericin B, it increases the risk of serious nephrotoxicity. So I'm not necessarily asking you to memorize all the nephrotoxic drugs, but be familiar with the fact that when amphotericin B is combined with other nephrotoxic drugs, it puts the patient at an increased risk for serious nephrotoxicity. In terms of individual variation, there's not a whole lot that we worry about here other than um, pregnancy. This is actually the safest antifungal for use in pregnant patients. Some of the other antifungals that we talk about in this lecture, there's just the data is not very good for use in pregnant patients. But this one is actually considered relatively safe for pregnant patients. In terms of nursing implications, I think these will make a lot of sense based on some of the adverse effects we talked about with this drug. First of all, you'll generally pre-medicate these patients to prevent the infusion reactions. So majority of patients who get amphotericin B will also get Tylenol and Benadryl as a pre-med. If the patient experiences Rigers, they may also receive a medication called meperidine, or the brand name is Demerol. But we don't just give meperidine to all patients on amphotericin, only those that experience Rigers during the infusion. And then we also give normal saline as a continuous infusion during and after the infusion, and that is just to serve as a kidney protectant. The infusion itself is usually given over a pretty prolonged period of time, generally about 4 to 6 hours, although if the patient tolerates the medication well, then that infusion time can be reduced. This drug does cause phlebitis, so you want to monitor for that, rotate infusion sites, or using a central line if possible. And then finally, this drug has a ton of compatibility problems. It's not really compatible with much of anything, so always check prior to administering this medication about compatibility.
All right, let's briefly talk about the liposomal forms. There are 3 different liposomal forms: Amphotech, Abelset, and Ambisome. These are the brand names. These drugs are not interchangeable, meaning if you give Ambisome today and tomorrow the pharmacy dispenses Amphotech, that's an error. They need to get the same form consistently. Same mechanism of action. Therapeutic uses are the same in terms of what the drug covers. However, because of the cost of this drug, the amphotericin B liposomal forms are much more expensive than the conventional forms. So because of that, they're reserved for patients who have failed standard amphotericin B, or patients who you don't expect to tolerate amphotericin B conventional because maybe they've already got some pre-existing nephrotoxicity and you don't want to take a chance that that might be worsened by the conventional amphotericin B. So for those patients, they might just get the liposomal form from the get-go. As I mentioned, the dose is higher. The typical dose range is 3 to 6 milligrams per kilo per day. However, sometimes doses higher than that are used. But for our purposes, definitely know that the dose range is 3 to 6 milligrams per kilo per day. This is just a picture of what the molecule looks like. In this picture, what you see is a liposome, and you can see that the amphotericin B molecules are embedded in that liposome. And so this is just an engineered dosage form that was engineered to help minimize some of the adverse effects. Administration, it usually is a much shorter infusion time than conventional amphotericin B. Some of the adverse effects, and these are compared to amphotericin B, There are usually less infusion reactions, and that's why we're typically able to give this over a shorter duration or a shorter administration time. Less nephrotoxicity, and like I said, that's really kind of the niche for this drug. So for patients that have pre-existing nephrotoxicity, this drug is preferred, and it also can cause less electrolyte abnormalities. Safety concerns. This drug is high alert. The reason why it's high alert is because there are mix-ups. Frequently, there are mix-ups between the conventional form and the liposomal form. What is typically seen is that the conventional form is ordered, but the prescriber orders the higher dose that's used for the liposomal form. And what that results in is increased risk for adverse effects such as nephrotoxicity or infusion reactions. Vice versa, if the prescriber orders the liposomal form, but they order the conventional dosing, then the patient is at risk for therapeutic failure. These are very serious problems. Like I said, you have to be familiar with this dosing just in general practice, but you should be familiar with this dosing for our exam. All right, let's move on. We'll talk about the azole antifungals. These are an alternative to amphotericin B. They are considered drug of choice for certain conditions. Um, but bottom line, the azole antifungals are also considered broad spectrum, just like the um, amphotericin B is. Its mechanism of action, it inhibits fungal cytochrome P450 enzyme activity, and this means that it decreases ergosterol production. In terms of adverse effects, you can see GI reactions, rash, headache, but the most serious, the most important adverse effects that you should be familiar with are cardiac effects on the heart and liver failure. And this drug has led to rare cases of liver failure. Some have been fatal, even in patients receiving topical therapy, such as eye drops. So this is a very serious adverse effect. All patients that are receiving azole antifungals, regardless of the form they're receiving, should be educated on signs and symptoms of liver failure. The azole antifungals are responsible for some very serious drug-drug interactions. These drugs are strong P450 enzyme inhibitors, which means that they impact the metabolism of other drugs, such as warfarin, some antidysrhythmic drugs, cyclosporin, which is an immunosuppressant. These are very serious drug-drug interactions. Now, you already know that ketoconazole and fluconazole are strong enzyme, P450 enzyme inhibitors. We memorized that from our first exam. Our prototype is itraconazole or Sporanox, but again, you should not forget about ketoconazole and fluconazole. All of these are strong P450 enzyme inhibitors. Some nursing implications. The capsules, itraconazole capsules, should be taken with food or cola. That increases the bioavailability. The suspension, however, must be taken on an empty stomach. If you take the suspension with food, it decreases bioavailability substantially. These drugs should not be given with antacids. If the patient is on antacids and they also need this medication, then these drugs need to be separated. At least 1 hour before or 2 hours after the antacid is given. And generally, we avoid giving H2 blockers or proton pump inhibitors for patients who are taking the azole antifungals. Patients must be educated on signs and symptoms of liver dysfunction. I have some of those listed on the slide. Definitely be familiar with these. Name recognition. I already mentioned ketoconazole. I mentioned fluconazole. Other azole antifungals in addition to itraconazole are posaconazole or voriconazole. So know that azole is your azole antifungals. That's kind of easy to remember. Our next class are the echinocandins. The prototype is caspofungin or cancidus. This drug disrupts the cell wall, causing cell death. Therapeutic use, this is more narrow spectrum than the first two drugs that we talked about. This drug is active against Candida as well as Aspergillus. For the most part, this drug is pretty well tolerated, especially relative to other antifungals, which can have pretty serious side effects. But this drug can cause fever, phlebitis, rash, headache, nausea, vomiting. But like I said, overall, pretty well tolerated. However, this drug should be avoided in pregnancy. The last drug I'm going to talk about is flucytosine. Brand name is Oncobam. This is an old drug. It's been around for a long time. Mechanism of action, it basically fungal cells take up the drug and convert it to active metabolites, and this inhibits DNA and RNA synthesis. It's used for cryptococcal meningitis, can also be used for candida endocarditis. But one thing I want you to know is that for both of these indications, this drug is used in combination with amphotericin B. So what I'm saying is that flucytosine as an antifungal is never used as single therapy. It's always used in conjunction with amphotericin B. Adverse effects. The most important adverse effect is bone marrow suppression. This drug can cause profound bone marrow suppression. It also can be hepatotoxic. Those are bolded on your slides. I think those are the most important adverse effects to be familiar with. Could also cause nausea, vomiting, diarrhea, like many other drugs that we've talked about. Some nursing implications. This drug is oral, and the dose that is needed for treatment of the diseases that it would be used for is pretty high relative to the capsule strength. So because of that, this drug, the dose may require up to 10 or more capsules per dose, and that can be difficult for patients. This drug can be administered slowly over about 15 minutes, which is very unusual. Most drugs are given over seconds, right? You just hand the medication to the patient, they get some water and swallow it. This drug, because there are so many capsules, it might take 15 minutes or so to administer the medication. Number one, because there are so many capsules, but number two, also to help minimize some of the nausea and vomiting that's associated with this medication. In terms of monitoring, kidney function, hepatic function should be monitored, as well as hematocrit, because I said this drug can cause some issues, some blood dyscrasia issues. And also, this drug is monitored by levels, so flucytosine levels will be monitored. All right, let's just talk for a moment about superficial antifungal agents. There are a variety of different superficial superficial fungal infections, such as dermatophytic infections, such as ringworm or onychomycosis. Well, let's talk about the candidal infections, though, the candidiasis. These are the ones that are seen most commonly. So candidiasis, normally where we see it, it can be seen anywhere on the body, but normally where we see it is vulvovaginal. And in that case, you could use, there are a couple different treatments that can be used. Fluconazole or diflucan, which is the brand name, 150 milligrams PO once. So that's a pretty effective, easy to tolerate dosage regimen for patients. Could also be used topically. So miconazole, brand name Monistat, is a cream that is used intravaginally. Depending on the formulation, it can be used either 1 or up to 3 days. What I think you guys will also see, especially if you work in the inpatient setting, is oral candidiasis. This is also known as thrush. There are a couple drugs that are used to treat thrush. Nystatin suspension, which is usually like a swish and spit or a swish and swallow, depending on the extent of the thrush. You could also see clotrimazole oral troches that are also pretty effective against oral thrush. All right, and that's it for the antifungal lecture. If you have questions about this lecture, please post them to the discussion board, and thank you for listening.